Good morning. Good morning. I'm Nancy Harper. I'm a child abuse pediatrician, and I'm the director for the Center for Safe and Healthy Children and the Division of Pediatric Emergency Medicine and Child Abuse. And the center is honored this morning to host Dr. Daniel Lindberg for our grand rounds. Dr. Lindberg was actually born in Minneapolis and is a proud alumnus of Southwest High School. He's an associate professor of emergency medicine at the University of Colorado, and he practices general and pediatric emergency medicine. He completed medical school at the University of Chicago and his residency in emergency medicine at the University of Cincinnati, where he also completed fellowship training in child abuse pediatrics. In addition to his clinical practice, he serves as a child abuse consultant, and he's an active researcher in our field of child maltreatment. He's led two of the largest prospective studies to test methods of evaluation for children with child physical abuse concerns. The Ultra Research Network determined optimal screening practices to identify occult abusive abdominal injuries. The Extra Network focused attention and determined optimal testing practices for the siblings and other children who live or are in homes with physical violence. Together, these research networks involved more than 20 centers, and we enrolled nearly 4,500 children who had concerns for physical abuse. Data from these networks, and this has sort of been really impressive to me, has improved our understanding of multiple aspects of child physical abuse evaluation, including initial and follow-up skeletal surveys, screening for abdominal injury in children, retinal examinations, neuroimaging, the evaluation of mimics of trauma, as well as multiple other topics. The scholarly work that resulted from these research networks has been incorporated into national guidelines, as well as even international guidelines, and has laid a strong foundation for a field that literally was only formally recognized as a subspecialty when both Dr. Lindberg and myself were in fellowship training. So with that, I am pleased that Dr. Lindberg accepted my invitation today to speak on cutting-edge diagnosis for child physical abuse. Thank you.
Well, thank you for that very kind introduction. It's really great to be back in Minneapolis today. I'm really happy to be here for two reasons. The first is, as Nancy said, I was born here. I grew up here. It's great to be back and see that winter can still get cold some places and that people can still survive. It's also really refreshing because usually when I talk about child physical abuse, I have to worry that I'm going to start everyone's day off on a down note and everyone's going to leave really depressed. But it's refreshing not to have to worry about that today because I saw the Minnesota-Wisconsin game, and I think that ship has pretty much sailed. We can just get to work. Anyone who's heard me speak before knows that this is not my usual topic. Usually, I talk about the tried and true, proven aspects of the examination for physical abuse, things that you have to do every single time, things that are really rooted in solid evidence. But today, I'm going to talk about more cutting-edge approaches. These aren't going to have as much data as things like your skeletal survey or your physical examination, but hopefully it'll give you a chance to be more on the cutting edge, to be an early adopter of some things. And we'll talk each time about whether or not I think each of these interventions are ready for prime time or ready to be implemented today, or if it's something we should just keep our eyes on the horizon about. I do need to start with some disclosure information. I am a paid expert witness in cases where there's concern for child physical abuse, and I do receive some grant support. None of the things I talk about today are going to be really off-label things, but they are kind of early. You did notice the title of the talk being Cutting Edge Applications. So what are we going to talk about? We're going to talk about new definitions of sentinel injuries. We're going to talk about fast MRI, which is where I've done my most recent work and where I get the most questions. And we're going to talk about something called universal screening and then routine order sets. This is not an exhaustive list of the cutting-edge interventions for child abuse. In 1 hour, I think we can go through these three pretty comfortably, but there are other innovations that you might want to pay attention to. So before I get into the data behind a newer understanding of sentinel injuries, let's review for a second what sentinel injuries are. There's actually some controversy about this. which we're not going to get into today. It's not really important to us. But the itch that the concept of sentinel injury is trying to scratch is that when I was in medical school, recognizing abuse was all about your gestalt, your impression, your spidey sense. There was a lot of time spent asking whether a parent's interaction with the child was appropriate, whether there were social red flags, whether the mechanism matched the injury, and whether the parents sought care immediately. This is a sign I actually saw in the Minneapolis-St. Paul airport just yesterday as I was coming in. This is about how to recognize human trafficking. And you can see we're pointing people to that sort of spidey sense. Does something just feel wrong? Does someone seem nervous? Do they avoid eye contact? This is exactly where our field was 20 to 30 years ago. And we had exactly as much evidence to back it up as this sign does, which is to say there's not a lot of evidence, right? So the field of human trafficking is where child abuse was 20 to 30 years ago. We know it's a problem. We know it's a much bigger problem than we anticipated, and we really want to do something about it, but we don't have a ton of evidence about what to do about it, and so we try our best. I don't have anything against this sign, but I hope that when I retire, this sign will say something that's very different, and that's what sentinel injuries are. I don't want to throw out all those concepts that are on that sign or things like delay in seeking care or that spidey sense that people have. I know that there have been cases where abuse was only recognized because of that spidey sense, but I do want to say that when that's all we had, we missed a ton of abuse. We still continue to miss a lot of abuse, and we created a system that was full of variability and disproportionality, where children who were in families that were Black or poor were much more likely to get investigated, and children in rich and white families were much more likely to have their abuse missed based on that sort of limited understanding. And so that's what the concept of sentinel injuries is. Thank you so much. So the concept, it's about finding those injuries where rates of abuse are high enough that it implies that we need to do something, even if it might not seem like a big deal. So Lynn Sheets in Wisconsin, right across the border, she published on the concept in 2015, and she focuses mostly on community members, like family members and CPS workers. And so she focuses on injuries in non-ambulatory kids that are visible to the naked eye. Nancy and I work a lot with frontline providers like emergency physicians and general pediatricians. And so we also include, pretty much any kind of injury that has a high rate of abuse, including things like fractures or brain injuries or abdominal injuries. And again, it's not so important which of these definitions that you use, but the idea is to identify a list of things where you don't want to ask yourself, is the interaction appropriate? Is there just something not right here? Are there social red flags? But we should do some sort of workup like a skeletal survey or a consultation to CPS in most cases. Now, when I say most cases, why am I not saying in all cases? Car crashes are usually the one that's exempted. And for those of you who are early, I see some candidates, there's a physical exam finding with a car crash that I like to call the Lindberg sign that helps you differentiate a car crash from others. It's if there's a crumpled car on the corner of an intersection, that's usually with a car crash. I haven't got the sensitivity and specificity of that, but it's a fairly reliable sign. And so if there's something like that where you know exactly what happened, well, then I'm not saying you have to get a skeletal survey in those kids, but in most other cases. So the classic definition, or the classic list of sentinel injuries that I don't think most people would disagree with, these are some of the things that we talk about. All sentinel injuries are associated with an age. You can certainly have a bruise if you're learning to walk, if you're running around, most kids do, but if you're less than 6 months old, pretty much any bruise is a sentinel injury. And this is not cutting edge. This has been known for a long time. But what are the new sentinel injuries? Well, I think in the last few years, this first one is one that we've really known for a while, but it's got some better data behind it. And this comes from Mary Clyde Pierce in Chicago. And she's really done a robust prospective study of children with bruising in pediatric emergency departments, confirming a lot of the things that we've been saying sort of by dogma for several years, which is this sort of 10-4 faces P. A lot of people have heard of the 10-4 rule, which is bruising in the torso, ear, or neck, or less than 4 years old. And when she says 4 years old, she means a 4-month-old, so less than 5 months old. I use 6 months old. This is, wars are fought in our specialty about this fine distinction. But then she also adds things like injuries to the frenulum, the auricle, which I think is really another fancy word for saying ear, the cheek, the eyelid, the sclera, and then injuries that are patterned, like this slap mark over here. So if you have these bruises, then this is really a sentinel injury, and it doesn't really matter whether you think it's a big bruise or a small bruise or a nice family or not a nice family. If you have these kinds of bruises in young children, you should probably be working up and probably reporting abuse in the vast majority of cases. The last couple of years have also identified exposure to family violence as a sentinel injury. And this is really, I think, exciting because this isn't a finding in the child, this is a finding in the household. And it's pretty intuitive that if there's someone in the household who sees violence as a tool to use when they have a problem, they're probably likely to use that tool in a lot of different circumstances. They're not really going to focus on one person. There are some cases where one child ends up being the scapegoat child and really focused on. But I think that we're learning more and more that when violence exists within a family, it's probably going to be a problem for lots of people in that family. So among kids less than 2 years old who share a home with an abused child, but where there's no symptoms, occult fractures occur in about 1 in 8 of those kids, in those asymptomatic kids less than 2 that share a home with an abused child. And that's a rate that I think is enough to justify a skeletal survey in all those kids. It's enough to justify a careful consideration of abuse in those kids. And then it's much higher in multiples, so twins and triplets. And when kids are brought to the emergency department because they're identified in a home with intimate partner violence, what we used to call domestic violence, rates of injury findings on skeletal survey or neuroimaging is about 1 in 4. And neither the history nor the physical exam is really good enough to identify all those injuries. So again, I think when you identify family violence in a home, you should think about that as a sentinel injury. Now, the other thing I think we need to talk about as a sentinel injury is unfortunately rather complicated. I'm usually very simple, and I'm never more simple than when I'm in a lecture setting with adults. And I think when it's dark outside and it's 7:30 in the morning, I should try and be a little more simple. But unfortunately, this is complicated. But I think it's really worth it. And the reason this is worth it is because this sentinel injury is designed to identify abusive head trauma. And abusive head trauma is really the goal for people in child abuse pediatrics, because abusive head trauma gets missed about 1/3 of the time, and this is the one where we really can't afford to miss it, right? So abusive fractures get missed about 1 time in 5, but as bad as abusive fractures are, if we miss it and then identify it a week later, we can still treat that. The child can still go on to do whatever they're going to do. But when we miss abusive head trauma and it comes back more severe, about 20% of the time, it's fatal. And about 80% of the other times, kids are left with permanent deficits for the rest of their life. And the rest of their life could be decades and decades. And so missing abusive head trauma is a big problem. So I hope you'll bear with me on this very complicated decision rule that was done by the group in Pittsburgh led by Rachel Berger. And so let's go through it step by step. The first thing is, who is this decision rule for? Okay, so part of it is in the name. It's the Pittsburgh Infant Brain Injury Scale. So this is for infants and not neonates. And what does that mean? That means you're 30 days to 364 days old. That's who it applies to. Second, it applies to kids who are well appearing. This is not kids who are in coma. Not that I don't want you to worry about kids who are in coma, but don't use this rule, just scan those kids. It's not for febrile kids, which takes out a lot of kids. A lot of times when I present this rule, people are like, oh my gosh, Lindberg, we're in flu season in the Twin Cities. If we are applying this to every fussy looking kid, we're going to be scanning we're going to be causing so much cancer. Not for febrile kids. And it's not for kids with a history of trauma. Again, I'm not saying it wouldn't be useful in kids with a history of trauma, but that's not where it was derived. That would, I think, only increase your risk. Okay, so first of all, that's who we're talking about, the population where abuse gets missed. Infants who are generally well-appearing, no history of trauma, and afebrile. What are they presenting with? Okay, so these are these non-specific things that, in the experience of child abuse pediatricians, when you look back at kids who end up having missed abusive head trauma, this is what they presented with. And here's the point where it includes a lot of kids. So kids who present with alties or bruies, whatever we're calling them, kids who have vomiting without diarrhea, okay? Kids with seizures or seizure-like activity or behavior changes like fussiness, sleepiness, etc., or lethargy, and then kids with an abnormal exam like bruising or soft tissue swelling on their scalp. So once there's that inclusion criteria, what does the rule say? Well, using logistic regression, they identified 4 things that we look at. And basically, the score that gives you a positive on the Pittsburgh Infant Brain Injury Scale is 2. So basically, if you're a young kid who presents with this and you have a bruise or an abrasion or an abnormal skin exam, you're positive. Otherwise, you need 2 of these things, but one of these things is age greater than 3 months old. That's just how it worked out in their relatively large sample. And so the 2 things you're looking at is really their head circumference and their hemoglobin. Okay, so most of the time, this is something where you don't have to do any additional testing besides your bedside exam. So if I can boil down this relatively complicated score, if you have a kid that enters like this and has one of these, start by looking at their head circumference and their physical exam. And if you've got 1 point after that, yes, I'm going to ask you to draw a CBC that you might not otherwise have gotten. But most of the time, you're either going to be a 0 and you don't need a CBC because it's not going to get you above 2, or you're a 2 or a 3 and you don't need a CBC because it wouldn't get you above 2. You're already above 2. But if you are, and if you do get that and you have a score greater than 2, in their sample, their positive predictive value for finding something on neuroimaging was 40%, which I think is certainly enough. I think that's compelling enough to get the neuroimaging in these cases, especially given the topic I'm going to talk about next. So my bottom line for these sentinel injuries is they're ready for prime time. I don't think there's a big downside for using any of these things. I think that the data is pretty compelling that the rates of abuse are high enough in kids with these things that it warrants a routine evaluation. So, if you have 10-4 faces bruising, then I would do a skeletal survey, neuroimaging, and most of the time I would file a CPS report. Again, same thing with family violence. I would do these tests. And then if you're positive on the PIBIS scale, I would undertake neuroimaging. Why do I say neuroimaging instead of head CT? I can get paid more by using longer words. Just kidding. But what we're going to talk about next is fast MRI. And for people who are really uncomfortable with doing that many neuroimaging tests, I think it'll be a lot easier if you adopt the idea of fast MRI. And this is where I've done most of my research recently, and I think this can address some of the concerns. So the itch that fast MRI is trying to scratch is that 99% of the time when people are talking to pediatricians about neuroimaging, they're reminding us that we're scanning way too many kids, and 99% of the time, they're right. Maybe not in institutions like this, maybe not in institutions like Children's Hospital of Colorado, but people like me who have a general emergency physician training, who see 1 or 2 really young kids a year who have traumatic brain injury and are really worried about missing that. Again, we talked about how this can really have long-term consequences. Lots and lots of those kids are getting head CTs. And so we spend most of our time telling people not to do that. But child abuse is different, right? And Nancy and I, when we are hearing about kids where there's concern for abuse, we're spending most of our time fighting against that tide, saying, you've got to scan this kid. And we're facing people who are saying, but wait a second, this is a kid with a femur fracture who looks great. Aren't you telling me all the rest of the time not to get head CTs in this kid when they look great? And there's a couple reasons why abuse is different. The first is that, in kids where there's femur fractures and there's concern for abuse, the rates of positive finding are much higher than kids who are in car crashes who look great. And the second is because in a car crash, you care about clinically significant injuries. But when you're talking about abuse, while you still care about the clinically significant injuries, you also care about the forensically significant injuries, right? So if a child rolls out of bed and has a small radius fracture, most people in this room are like, most kids who don't roll out of bed, who roll out of bed don't have a radius fracture, but it's not impossible. And the ways that we address abuse can have big downsides. Removing a child from a home, removing a boyfriend from a home, removing someone who pays rent from a home, that's a big intervention. You want to be as sure as possible. So that same child who rolled out of bed and has a radius fracture, if they roll out of bed and have a radius fracture and a subdural hematoma, that stops being a hard case. It starts being an easy case, and it helps make the case for secondary interventions to prevent further abuse. So could we use a standard MRI, right? So standard MRI has great possibility. I mean, it's great imaging. There's some concern that it may not pick up skull fractures or subarachnoid hemorrhages, but it really images the brain pretty well. The problem with a standard MRI is that I've got 2 kids who are 9 and 5. They're really well behaved, but for a standard MRI, you got to hold still for 30 minutes. I got to tell you, for love or money, I cannot get my kids to hold still for 30 minutes in the best of times, much less when they're in a scary emergency department. So a standard MRI requires sedation. Sedation has 2 problems. The first is that there's some concern that it might have some risk to use sedation. Of course, there's allergies and stuff like that. But some of the neuroscience is making us wonder whether there's actually a small cognitive effect of sedation. Now, this is controversial. It's as hard to measure as it is from radiation. But if I gave you a choice between 2 tests and told you that one of them had a 1 in 1,000 risk for cancer, and the other one, on average, lost about 1 IQ point or half an IQ point for your child, which would you pick? I'd honestly might go with the one that causes cancer, because if the kids get the cancer, they're going to get it in 20 or 30 years. And I know that the good people at the University of Minnesota and all over the world are trying to fix cancer. 30 years from now, we might have that fixed. So sedation is a problem. But the real reason we don't use standard MRIs is because we can't get it done. And when someone says, well, I'm concerned about the radiation, and I say, well, if you're concerned about the radiation, maybe you should just get an MRI. I know exactly what I'm doing. I'm being passive aggressive. And over the end of the phone, I can hear their eyes roll. Oh my gosh, I'm going to get a pediatric anesthesiologist into the hospital at 2 in the morning. I'm going to get time on a standard MRI scanner for 30 minutes. And they say, okay, I'll just get the CT. So fast MRI is not a problem because it's not good imaging. It's a problem because it's not feasible in an urgent setting. Sorry, standard MRI, I should say. So what is fast MRI? I think most people in the room know the concept of fast MRI. It's not a new scanner. It's just new sequences. And people have used fast MRI for decades now to look at kids with shunted hydrocephalus. But it's not a slam dunk that we could use fast MRI for trauma the way we do for shunted hydrocephalus. Because for kids with shunts, what you're looking for is the ventricles. And the ventricles have 2 really well-behaved properties. The first is they light up like a Christmas tree when you image them. And the second is they tend to be in the same place inside a child's head. Now, blood might be a little different. This is a very large parenchymal bleed, and it's large and you can see it. But imagine if it was much smaller and you had no idea where to look. So it's not a slam dunk that we can use fast MRI for traumatic brain injury. And so we studied this at our own hospital. This was children who came to a single emergency department, an academic emergency department, in a place that's warmer in the wintertime and has less humidity. Don't hate me. And so we said any child who came to our emergency department who was less than 6 years old, who got a head CT in the course of their care, would be eligible for the study. At first we said, and there was concern for traumatic brain injury. But we stopped saying that because we missed all these kids that weren't included, and we said, why wasn't this kid included? And they said, well, I wasn't concerned for traumatic brain injury. And we said, well, why did you get the scan? They said, well, they were throwing up, they had a bulging fontanelle, and they had seizures. We said, why weren't you concerned for traumatic brain injury? And they said, well, everyone seems so nice. So we said, look, okay, we're going to exclude you if you already have a known diagnosis of something that wasn't traumatic. Like you know that the child has a tumor, you know that the child has meningitis, that child would be excluded. If they were, certainly if they had contraindications to MRI, if they had a prior known traumatic brain injury or structural brain abnormality, like a shunt or neurosurgery, or if they were too unstable for us to have a consent conversation, we excluded them. And so in the course of our study, about 1,200 kids had head CTs performed or uploaded who had gone through our emergency department. And we were able to approach about 700 of them for consent. 400 said no, 300 said yes. Of those that said yes, the MRI machine wasn't available before the patient was discharged in about 65 kids. There were 5 that withdrew their consent. This was often because the child was crying or they were ready to be discharged. There were 3 new contraindications in between the time that they consented and the fast MRI was available. 2 of those kids became clinically unstable in the time afterwards, and 1 child had staples placed for a scalp laceration, so they couldn't get an MRI. And then there was 1 scheduling error. So later we're going to talk about how feasible the study is. And again, we tried to get the fast MRI within 24 hours of the CT, and that was true whether we got the CT in our department or whether they were transferred from another department. Our fast MRI was available from about 6 a.m. till about 11 p.m. So if you came in at midnight and got consented and you got a negative CT and went home, that's what we mean by the fast MRI was not available. But we attempted the fast MRI in 225 kids. About half of the kids where we attempted the fast MRI had something on the CT. So you can tell this is a pretty enriched population. You know, when people get a CT at an outside hospital and it's negative, they're much less likely to get transferred to our hospital. If people get a CT in our institution and it's negative, they're much less likely to wait around in our observation unit for the fast MRI to become available. So about half the kids had a radiographic injury on the CT, and most of those kids had skull fractures. About half of those skull fractures were isolated skull fractures and half were associated with other injuries. For the math majors in the audience, you'll notice that these numbers add up to more than 111, and that's because kids could have multiple injuries. So let's first talk about whether or not we can do this. 8 kids got sedation, and we didn't give any sedation to do our fast MRI, but if you got sedation for another reason, we didn't exclude you. 8 kids had gotten some form of sedation for another reason, either for a procedure or in most cases because someone wanted the full MRI. And we excluded those from our feasibility outcomes. 2 kids that we attempted our fast MRI couldn't get their fast MRI. 1 was because the child was moving too much and we couldn't get them to hold still for the fast MRI. 1 was because the child was crying and the parents said, I want you to stop, they've been through too much, and that was one of our predetermined stopping rules, so we stopped. But that means that we were able to get the fast MRI in 99% of the kids, and while the median imaging time of 6 minutes was definitely longer than a CT, it's still something that's feasible, both in terms of are you willing to be away from a child for 6 minutes, and can you squeeze them into the MRI schedule while another kid is coming down from the ICU? So we thought it was very feasible, and none of you will care about that until I show you whether it was accurate. So good question, I'm glad you asked. So of the 223 kids that got the fast MRI, there were 18 disagreements. And that gives us an accuracy of 92%, which is less than we were hoping for if we use the CT as the gold standard. Again, sensitivity 93%, specificity 96%. But the question is, should the CT really be considered the gold standard? And for that, let's drill down into some of those disagreements. So there were 8 kids where the fast MRI just missed the injury, and 6 of those were isolated skull fractures. 2 of those were subarachnoid hemorrhages. Those were just misses. When we really looked at this as closely as we could, we think that there were 5 cases where it was really the CT that missed the injury. And those were 3 subdural hematomas, 2 contusions, and 1 subarachnoid hemorrhage. 1 child had a subdural and a contusion, so 5 kids. There were also 4 children where the CT was read as unclear. And specifically in those cases, what that meant is the CT said, I don't know if these are large subarachnoid spaces or chronic or old or dark subdural hematomas. And the fast MRI pretty conclusively said, no, they're in large subarachnoid spaces. And then there was 1 case where the CT was unclear and the MRI didn't show us what the CT raised the concern for, but we didn't trust the MRI to say it was truly negative. So both are really read as unclear. Let me show you a few of these cases. This is what a skull fracture looks like on a CT. It's a bright line that waves at you and says, I'm a skull fracture. And this is what it looks like on an MRI. It's a dark area that says, I'm completely normal, keep looking. So we missed the skull fractures in 6 cases. And subjectively, the radiologist felt that the occipital skull fractures were the ones that were much more likely to be missed. These are the subarachnoid hemorrhages. This is the point where you go, Dan's just trying to make his research look good, and you ignore what I'm saying, but they were really small. And these were the cases where the fast MRI was delayed 15 or 23.999 hours. So maybe it just redistributed. These are the excuses I'm making for missing the subarachnoid hemorrhages. This is what it looks like when a CT misses an injury. So this is the kid who had the subdural hematoma and the contusion. You can see they jump right out on the fast MRI, and we don't see them on the CT. So I'm pretty proud of these results. I think this is important, but there are some limitations. The first is generalizability. We work at a center that has 4 MRI machines, as close to the emergency department as that exit sign is to me. So it's very close. We used 3 Tesla scanners. We used extremely experienced MRI techs, which is very important, and board-certified, sub-specialist trained pediatric neuroradiologists who are interested in MRIs. So if you try and implement this in a center that has a 1.5 Tesla scanner and doesn't really image a lot of kids, you may not get the same results. Also, image quality is not a static thing. So specifically, half of our kids got their CTs at outside hospitals, and those outside hospitals rarely use 3D reconstructions for their skull. So there may have been some small skull fractures that were missed on the CT and on the fast MRI, and that might have made our results look better. Also, how much motion you're willing to accept is going to affect both our feasibility and our accuracy. So if you're a tech that really won't say the scan is finished until you have 0 motion, the time that it takes to do the scanning is going to get longer and your accuracy is going to improve, and vice versa. And then last of all, even though I'm very proud that 95+% of our kids were imaged within 24 hours, that could still be a longer or shorter period, and injuries may have become more apparent or less apparent over time. Most of our fast MRIs were done after our CTs. 12 were actually done before, but that can affect our interpretation. So there's that. So my bottom line is I think fast MRI is ready for prime time, and I think people should start using it. I'm not going to say it's better than CT, but I think they're probably pretty equivalent. And I think the lack of radiation settles the tie in favor of fast MRI. Now, our radiologists felt like they got better at finding skull fractures over time. And so if someone thought this was the right thing to do, what I would recommend is starting at their center with kids who have traumatic brain injury, who are identified either by CT or whatever process, and who get admitted and who require follow-up imaging. So at our center, kids with abusive head trauma routinely get a full MRI at 72 hours. There are lots of kids who are admitted to the neurosurgical services and they drop their GCS or they blow a pupil and require subsequent imaging. Those are the kids where I would do a fast MRI, because you can compare apples to apples on their initial imaging study. You know exactly where you're looking, and you can say, am I seeing all the injuries that we identified on the first scan? And so I think that can really get to a point where you say, I am or am not comfortable with fast MRI as an imaging study. Okay, next I'm going to talk about universal emergency department screening. And in my darker moments, I sometimes wonder whether anything I've talked about so far really affects anything at all. Because when you talk about missed abuse, you're really not talking, in most cases, about someone who thought long and hard about whether or not to get a head CT or whether or not to get a skeletal survey or whether or not to use fast MRI instead of head CT. You're usually talking about someone who blissfully walked past an injury and thought, everyone's nice, who cares? Abuse didn't even cross their mind. Once abuse crosses your mind, the battle is almost won when it comes to finding the abuse. And so that's the itch that universal screening is meant to scratch. And again, universal screening doesn't mean a skeletal survey for everyone who comes into the emergency department. It's just talking about a moment where we take a time out and think, for every child who hits the emergency department, is abuse a possibility in this circumstance? So it started in the Netherlands. And in my experience, the Netherlands they often publish these great acronyms for their studies, and I have no idea what the letters stand for. And this is one of those cases. This is the ESCAPE tool. Capital letters, periods after all the letters. I have no idea what the E in ESCAPE stands for, but that's what the tool is. I assume it has something to do with speaking Dutch. So the ESCAPE tool was the first approach for this. And in the Netherlands, they said, we're going to use this paper form with these 6 questions. Every time a child less than 18 years old comes to the emergency department, the triage nurse is going to ask each of these 6 questions. And if one of those is outside of the boxes, then we're going to think about abuse. And some of these make sense. Some of these look like the sign about human trafficking, but some of these definitely make sense. Is the history consistent? Was there a delay in seeking care? Does this fit with the developmental level of the child? Here's where things go a little bit off the rails. Is the behavior of the child, his or her carers, or their interaction appropriate? And I think translated from the Dutch, this study might say, insert preconceived biases here, right? That's really what the question invites you to do. Is there a finding on the head-to-toe skin examination? And then are there any other signals? And this is the point where I get into trouble, because I love this question. And this question could also be translated to insert your preconceived biases here. But when they studied the tool, this was the question that had the best sensitivity and specificity for abuse. This basically gives the triaging nurse permission to use their judgment and say, are you concerned for abuse? It asks them to take a pause and give their opinion, and it's the most useful question when they look at this. So this is what they showed. They showed that over a couple of years when they implemented this, in about 38,000 ED visits for kids less than 18 years, they actually got the paper forms completed about half the time. And the paper forms were positive about 1% of the time. So what does that show? It shows that you can implement this without grinding your emergency department to a halt. It shows that you're not going to be doing skeletal surveys on every single kid who comes by implementing this tool. Then of the kids who had a positive screening, about 10% at the end of the day met their criteria for, we think this child is probably likely to have been abused. What does that tell you? Again, it tells you that you shouldn't, once the kid pops positive on this screening tool, it's probably a big enough concern that you shouldn't just blow it off. And don't pull the big red lever on the wall with lights and sirens and report every child. Just take some time to think about it. Maybe do a skeletal survey, talk to the nurse should definitely talk to the provider should take it seriously. But just because you're positive on one of those 6 findings doesn't mean that it's abuse every time. So I think as I've presented this, you're thinking, okay, maybe it's a good project, maybe it's a good concept, but there's definitely ways we can improve it. And the title of this talk could have been Stuff Rachel Berger is Doing That's Really Neat. And so she went on to try and improve it. The first thing she did, which everyone in the year 2019 is thinking we should do, is, okay, what is this paper form that he's talking about? What is paper? No one uses that anymore. Let's put it in the electronic health record. And then let's solve some of those issues. So a lot of the questions are very similar. Is there a delay in seeking care and inconsistent history? This is the wild card question that allows the nurse to put in their own judgment. And then they got rid of the question about, is the interaction appropriate? Is the caregiver's eye contact appropriate? And they added a question instead about poor supervision or neglect, and they put some meat on the bones of an abnormal physical exam, raising the possibilities of these sentinel injuries that we talked about earlier, like these bruises and burns and subconjunctival hemorrhages. And they implemented this in 13 emergency departments in the UPMC health network. One of those is a big ivory tower pediatric medical center like yours. The other 12 are general emergency departments. And they showed that they implemented it for kids less than 13. And they had 17,000 kids in their sampling frame. They were able to get screening completed in 68% of kids. And again, only 2% were positive. They're not able to really follow those kids to say if any of the kids that were negative, did they end up being abused? At our center, we've tried to boil this down even further, so there are fewer clicks. There's the same number of questions, but we squeezed them into 2 little clicks. So the idea is that nurses have to consider each of these different components, but they only have to click a couple boxes. The first is there something about the history, like delay in seeking care or inconsistent history? And the second is there a sentinel injury, like 10-4 faces, bruising, et cetera? And if they click either one of these things, they're asked to comment, what were you concerned about? And then the provider has a hard stop before they can discharge a child that says, did you think about this? We hate hard stops, but the reason for that hard stop is we wanted it to be a never event, that the provider goes home, comes back the next day and starts signing charts from yesterday and goes, oh my gosh, someone was concerned for abuse and I didn't even know about it. So my bottom line in this case is that this is probably an optional intervention. Okay, we don't have the sort of evidence we need to show that this is actually going to decrease abuse, but I think many of you have seen this sort of quadrant analysis where you look at how hard something is to do and what the payoff is. And if it's really easy and the payoff is high, you should just do it right away. If it's really hard and the payoff is low, you should not do it. And if it's in either of these other 2 quadrants, you should think very carefully. I think that this intervention is probably somewhere down here, where the amount of effort it takes to implement this system is pretty low. I think we can all remember when Ebola started being a thing and everyone started asking everyone who came to the emergency department within a week, have you been to Sierra Leone? Have you been anywhere where there's Ebola? It can be implemented very quickly. Now again, it's a couple clicks every single child who comes into the emergency department, so that's a lot of clicks over time. But I think that the impact, if it can identify 1 or 2 cases a year of abuse that would otherwise be missed, that can be a pretty dramatic impact. The question is, does it? And we're trying to do the research to really test that on a statewide level, and so stay tuned. But I think right now, this is something that, if you have the resources to implement it, is probably a reasonable thing to do. And the question is, how long will it be optional? And fortunately or unfortunately, depending on where you are in the system, a lot of certifying organizations have decided that it's probably a reasonable thing to do. So if you want to be a pediatric trauma center, I think the American College of Surgeons Committee on Trauma is pretty soon going to require something like this in the near future. And I just want to show, this was the group that did the ESCAPE trial, and they said, once we implemented these paper forms, we had a great increase in people using them. That probably means that people like them. But what they don't mention is that halfway through their study, the Netherlands government required this for every child who comes to the emergency department. And so you can see this is what we call a secular trend in the fancy research world. So they think it was because their forms made sense, but I think it probably also has something to do with the law being implemented. So once we start thinking about the EHR, we should also talk about ways to make things easier after the concern for abuse has been raised. And again, Rachel Berger has been leading this movement and has created order sets for both EPIC and Cerner. And what you see here is a standard order set that's being deployed at Children's Colorado. I'll show you Rachel's later. And when I started designing this based on tools that Nancy and others have described, I thought it would be pretty simple. If you're less than 6 months old, you get tests A, B, C, D, and E. If you're 6 to 12 months old, you get A, B, C, and D. If you're greater than 12 months old, you get A and B. But it turns out it's actually much more complicated than that. And a child who's 12 months old with 3 rib fractures is different than a child who's 12 months old with bruising. And so building these order sets was not something that would fit in a simple text box or a simple pathway. And we ended up having to create several dozen order sets based on the presenting injury, the child's age, and whether or not there's a traumatic mechanism. But now, once you've entered those data, you get these nice pre-checked, these pre-checked order sets that tell you what to do, what's optional, what you shouldn't do. And then Rachel took the next step, which is she linked that with universal screening. So she's implemented universal screening at her center, and if the triage nurse clicks something that's positive for that universal screening, then it gives you the order sets right away, and it's this seamless pathway. So using our quadrants, I think this is also optional, but I'm less interested in doing this than I am doing the universal screening, because let's face it, at this point, this is an intervention once you're considering abuse. So I really think this is less likely to identify a kid that would otherwise have gone home with no intervention. And the amount of effort it takes to program these order sets and use them is a little bigger than the initial order set. So this may be useful, but the rewards we're talking about are not preventing a kid from going home with no recognition. We're talking about getting rid of disparities in screening. We're talking about doing things the same way every time. Worthy goals, but just not as big a deal. So for these 3 interventions, are they ready for prime time? I think that you should definitely start using the new concept of sentinel injuries and these new sentinel injuries tomorrow. I would hope that most centers like the University of Minnesota might at least try fast MRI and see if it works for them. And I think it's optional for whether or not to use universal screening or standardized order sets. And thanks very much for coming, and I wonder if anyone has any questions.
Thank you very much. So wondering if we have any questions before I ask any of my own.
So thank you very much. This is a hematologist question. So in the Pittsburgh infant brain scale, hemoglobin less than, what was it, 11.2? Why?
Right. The answer is because that's what came out of the logistic regression model. And there's questions about whether or not it has to do with nutrition or recurrent trauma. You know, a lot of people when they see bleeding in the brain get a CBC to look for anemia. In my career as an emergency physician, I've never had anyone drop their crit from bleeding into their brain without other really, really, really bad things happening first. So I don't know the answer to that, but people have speculated about that. But the reason was, over and over again, it came out of the model. I will say this was a derivation with validation, and so they were very suspicious of whether or not this would be validated, but it turned out that it was validated after they saw the signal initially. It's been a pretty strong signal.
Although we do seem to see like anemia in some of the children with abusive head trauma, so I don't know if that's sort of where it came out too.
Before you leave this slide, I'm all aboard with everything down to number 6 here, and that's where we start to have this huge iceberg of patients that come in with nonspecific symptoms like that, and I just wonder, were they able to make a distinction between some of these criteria and then number 6 they threw in there just to get to 100%, or, you know, I kind of wonder how many patients that's going to, end up being.
So they didn't subsequently sub-analyze this. The reason Rachel doesn't like this number of 39.5% as a positive predictive value is she admits that this study is not all comers to the emergency department. These results are for everyone that they enrolled. And this is definitely where you get some amount of subjectivity. And the way I operationalize this in my life is that I just feel like I know it when I see it. And I know the difference between a kid who has a cold and is fussy or has, is just a little fussy from what they're talking about, and people who come in with a complaint of my kid's not acting right? The last time I used this was someone who said, this child has woken up twice in the last 19 hours. I really had to make them feed, and that was the only thing. And a lot of my colleagues said, we shouldn't image this kid, that's too much radiation. This was back before we had fast MRI. And this wasn't an abusive head trauma, this was a cerebral sinus thrombosis. But I guess I would say it's okay to, with the experience of a pediatric emergency physician, separate a child who happens to be fussy and comes in with a different chief complaint and a kid who comes in for fussiness and behavior change.
I mean, a good example, because one actually came to your emergency room, I think it was about a month or so ago, was a 2-month-old where there was that inherent bias because mom had CPS involvement, prior drug use history, and it had a couple of visits to the primary care doctor for fussiness, crying, and nobody could figure out sort of the why. And so they sent to the emergency room because, of course, it had to be child abuse because she had a CPS history. So I worked through this with the resident on the phone, and the baby didn't score, and we didn't neuroimage because everybody was saying, should we do a CT to make sure that this child doesn't have head trauma just because of fussiness and a CPS history?
But I'll admit, you see 10 of those a day, and we get filtered the ones that are positive. So it's a legit question.
How do you control for racial profiling with your universal screening? I don't think universal screening will eliminate all intrinsic bias, but I think it helps
because I think without universal screening, you still have people bringing up this question based on their subjective impressions. And I think subjective impressions are the bigger problem, is that people forget to think about it in kids who look like my kids. And so by prompting people to think about it in everybody, not just kids who look poor or whose parents look different from them, I think that helps to decrease the amount of intrinsic bias. I don't think it will by itself eliminate intrinsic bias, but I think it is a step in the right direction.
Just a couple quick questions. One is fast MRI available 24/7?
It's only available about 18 hours a day.
Okay, and how does that... It is for you. Yeah. And how does the cost compare between fast MRI?
That's a great question. And in the United States, just determining cost of medical procedures is very, very complicated. And so I can't give you a direct answer for the cost. But I will tell you that at our center, even when we were talking about shunted hydrocephalus, and certainly for traumatic brain injury, the radiology department kind of went back and forth with insurers, and insurers very legitimately said, we're not going to pay the price we pay for a full MRI. For a 6-minute MRI, we're not going to pay at all. And the radiologist said, well, you can't just not pay at all. And what they landed on was, we're going to charge you the same amount for a fast MRI as we do for a head CT. And the radiology department feels like that's reasonable, that they're not taking a bath on that situation. I expect it will probably change as more evidence comes out. But it's much less than a full MRI, given the amount of time it takes in the scanner and the lack of tech. It probably costs more than a head CT.
And one last question about radiation risk. And as a radiologist, I'm all about radiation risk. However, the brain is one of the least sensitive radios. In terms of radiosensitivity, the brain is not very sensitive at all to radiation. I do worry about cataracts with irradiating the lenses. But do you have data that shows that there's a 1 in 1,000 risk of cancer if you're doing a head CT?
I don't have great data. I'll tell you what I know. So that number is taken, it's actually about 1 in 1,200. And that was taken from the study in Australia with 680,000, where they looked at kids who had, or actually all people who had gotten a head CT versus those who hadn't, and their 30-year risk of cancer. And the number they came up with was 1 in 1,200. For abdominal CTs, I've heard estimates of like 1 in 500, and I don't know if it's 1 in 2,000, 1 in 1,200, 1 in 500, but I think that's the neighborhood we're talking about. It's somewhere in that area. I think there's pretty good evidence that there's not a threshold where if you're below that threshold, it's zero risk. And so I think reasonable people would agree that the risk is pretty low. And if you've got an indication to do the scan, you should do the scan. And if you don't have an indication to do the scan, you shouldn't do the scan. And so when I get consults from Our Lady of the Faint Hope Emergency Department, and they're not going to transfer a child who doesn't really need it and the child is stable, I'm perfectly happy to do a CT scan. And I'd much rather do a CT than nothing, but given the choice between a CT and a fast MRI, like at an institution like this, we're pretty much moving to the fast MRI, because I think in those cases, it's often the choice between doing the fast MRI and doing nothing, because people are so worried about the radiation, which I agree is probably overblown.
Excellent. Any other questions? Well, you may see a lot of our physical abuse charts around the emergency rooms here and at Hennepin. We have sort of an age and injury approach that includes most of the sentinel injuries that he was talking about today. We are trying to also make a smart set, but like everything else within the Fairview Health System, it's on some priority list, and I suspect it's near the bottom. So if you have any pull, let me know, because we would love to work on our smart set here for our ED and inpatient colleagues, similar to one at Colorado. And with that, I thank everyone for coming today. And if you have other questions, you are welcome to come up and talk with Dr. Lindberg. Thank you.